Okay, we're going to move on to our last speaker. This is Dr. Terashima from Tokyo in Japan. He's a cardiologist who's been practicing for many years and worked in California at Stanford, and he runs the largest private cardiac imaging clinic in Japan. And he's going to talk to us about his experience with Toshiba 1.5T magnet.
Thank you, John. My name is Dr. Masahiro Terashima from Tokyo, Japan. So different from previous grade 2 speakers, I came from is entirely clinical field. So I'm running the cardiovascular specialized imaging center in Tokyo, Japan. I want to share our experience of cardiac MRI by Toshiba 1.5 Titan scanner. I'm gonna show you the Japanese statistics. These topics may be a little bit related to Dr. Lima's talk. I'm gonna show you this is the number of cardiovascular imaging study in Japan. So you can appreciate the rapid growth of coronary CTA. Probably is very close to invasive coronary angiography, but not yet overcome coronary invasive angiography. But it's getting very close. But you can see its cardiac MRI is pretty low. It's just around 20,000, something like that, but now increased to 34,000. But I believe, or probably most of the audience here believe it's a cardiac MRI is underutilized in Asian countries, especially in Japan. I'm gonna show you that today's my talk is the first is I'm going to show you the how Toshiba coronary MRA improved image quality. And also CardioLine and also future version CardioLine Plus, that is a knowledge-based recognition of the LB. And now it's expand that knowledge-based recognition to RB and barrel. And also first, Toshiba's new technique, the KT speeder, new acceleration technique, is much faster to get MRI image. And also accurate, it's Toshiba's new myocardial strain technique to assess based on cine MRI, we can get the strain image or strain analysis. And also finally, I'm gonna show you it's a patient comfort technique by Toshiba. This is a typical study in our center. Full study, it's usually called the one-stop shop for cardiac MRI. We can start from cine MRI and move on to T2-weighted imaging and coronary MRA. And also we inject contrast agent using the pharmacological stressor to get the stress perfusion MRI. And waiting a couple of minutes, we start the rate gadolinium enhancement. That study may take probably 1 hour or 60 minutes in our center. And to get nice image of the coronary MRA, Dr. Sakuma mentioned, it's a respiratory navigator is very, very important. But as a coronary MRA current technique, it's with 32 channel, it takes 15 to 20 minutes. The patient may fall asleep, and the patient just move or takes longer, and move the respiratory motion is pretty bad to get nice coronary image. Some of technique to improve efficiency of the respiratory navigator is Toshiba's technique is change the respiratory navigator wise and drifting line to get the nice efficiency of respiratory motion. We can move the respiratory navigator line to get acquire the patient the diaphragm motion. So using such technique, probably not many people have ever seen the Toshiba coronary MRA. As this is a compare its other vendor, it's Toshiba MRA can get quite nice image quality. So you can appreciate here. And also, it's a good technique. It's a CardioLine. So this technique is developed by Toshiba and also the professor, Dr. Nitatori at Kyoto University in Japan. They collaborate together and get a nice knowledge-based recognition technique. So we can just start to scan to recognize the 3D structure of a heart to immediately get a nice view, and you can appreciate three-chamber CMRI as immediately. With this technique, it's this data from another institute in Japan. At the beginning, they took 70 to 90 minutes for full study, but with CardioLine, they can just make short as 47 minutes. Especially in non-contrast MRI study, as they just get 23 minutes. It's a quite dramatic decrease of scan time. That is very important technique to get nice image quality of coronary as well as cardiac MRI. And also now, CardioLine is upgraded to CardioLine Plus. This is the next version to get the RB and as well as valve plane in addition to LB planes. So we can automatically get 14 planes instantly. I'm going to show you a couple of cases to severe MRI. As this patient is a 59 years old gentleman. So he has dyspnea on effort, and he has COPD as a lung disease. He has a history of further as a sudden cardiac death. That's surprisingly, he's a current smoker. It's pretty bad. And we scanned his MRI. You can appreciate the cine MRI, but some cine MRI as an artifact you can appreciate, but you have to remember this patient is a COPD and smoker. He cannot hold breath. But we can get quite nice image of its diagnostics. And coronary MRA, we can see it's some narrowing of the LAD in the mid-LAD. Unfortunately, we cannot get invasive coronary angiography data. That's not always, but we usually compare with the contrast CTA. So you can see it's a heavy calcified LAD, and within calcification, so you can see the severe stenosis in mid-LAD. That is a steep learning curve for us to compare coronary MRA and coronary CTA, how it looks like the severe stenosis and also moderate stenosis as well. To carefully compare, as a previous talk Dr. Sakuma mentioned, it's the stenosis may look like the narrowing of the lumen on coronary MRA as well as the signal drop. The two factors we have to take into consideration to make a right diagnosis. That is, sometimes it's very challenging, but experience with many cases, we can improve diagnostic accuracy. And I have to move on to the next case. This case is a 75 years old gentleman. He has effort angina since 2 months ago. And his cine MRI looks like this one. You can see is mild impaired LV function. And the perfusion image, so you can appreciate it's a perfusion defect. It's not great image quality, but you can see it's anterseptum and also it's lateral wall, it's some perfusion defect. And that may imply it's a multi-vessel disease such as the LAD and the circumflex artery. So with LZE, we can see the small, tiny spot in the lateral wall. This is a very important information, as Dr. Lima mentioned in the morning. It's unrecognized MRI. It's a fibrosis and a scar. This small scar could be very important for prognostic information for the patient with the coronary artery disease. And we move on to the coronary MRA that is surprising. It's a left main system. There is severe stenosis. That's why we transferred this patient to the hospital by ambulance. So he got emergency coronary angiography. So you can appreciate the very severe stenosis in left main system. And the following the invasive coronary stenting, the patient got a pretty nice stenting in the left main system and discharged 2 days later without any complication. Now I'm going to show you it's a couple of non-ischemic cases. One is a 54 years old HCM patient, the congestive heart failure, and the elevated BNP. You can see it's a thickening of the septum. Especially the septum is asymmetric hypertrophy, we call ASH, that is typical for HCM. The teeth-weighted imaging, it's RB insertion point, there is a high intensity signal that implies is myocardial edema. And the stress perfusion, as you can see, is a small perfusion defect. And also coronary MRA is non-coronary stenosis. But the LZE clearly show it's a high intensity or scar, it's RB insertion point. But I want to emphasize this Cine MRI contains some artifact, but you can go back to the EKG. This patient is atrial fibrillation. But we can still get the diagnostic quality of image. That is very good for patients and for us. Another example is this patient is also very, very challenging. You can see it's EKG, it's a frequent PVC that you can appreciate, but this patient, you can get the Cine MRI with some artifact, but I think it's still diagnostic. It's dilated LV and also thinning of the left ventricular wall, anterior, and also inferior and apex. These sites, you can appreciate a teeth-weighted imaging, the high signal is there, and also the LZ, you can see the scar in the basal septum, that is a frequent portion of the cardiac sarcoidosis. The coronary MRA also reveals no significant coronary stenosis. Based on the previous reports and also our own experience, probably the 50% of cardiac sarcoidosis has coronary artery disease type LZE. That's why it's very, very important to distinguish that it's a coronary artery disease or ischemic heart disease or the sarcoidosis. Sometimes it's overlap or just combined, but the coronary MRA gives us the nice solution to distinguish sarcoidosis from coronary artery disease. Let me move on to first. It's a new acceleration technique by Toshiba. It's a KT speeder. That KT speeder is doesn't require as a training session, so we can acquire full RR acquisition. That's why acceleration factor is 4 to 8 times. It's pretty fast technique to get a nice image. Using this KT speeder, it's usually to get the stack of short axis imaging, we have to ask a patient multiple breath hold. But using this KT speeder, we can just get one breath hold, entire stack of short axis imaging. That makes the cardiac MRI study much shorter. Now I'm going to move on to a new technique for myocardial strain analysis. Conventionally, to get myocardial strain, we have to use the myocardial tagging. The myocardial tagging imaging is very useful, but that myocardial tagging imaging has a disadvantage. One is we need additional scan to get tagging. And also to analyze myocardial tagging imaging, it's very time consuming, it's painful. But new technique by Toshiba, it's Cine-based strain analysis. This Cine MRI we acquire routinely in a part of cardiac MRI study. Based on this Cine MRI, we can analyze to get myocardial strain information. I have to emphasize, it's right two slides, it's a longitudinal strain. That is a very important strain information. It's usually the myocardial tagging, we can get just a transverse strain. The longitudinal strain is impaired earlier than transverse strain in myocardial infarction case. That is the reason why this technique may be a promising technique for myocardial strain analysis. Finally, I want to talk about the patient comfort. Every cardiac MRI operator knows it's a successful exam begins with comfortable patient. The patient move, or patient just coughing, or patient just tired. That is a disaster for cardiac MRI study. The Toshiba has basically 3 techniques. One is the wide bore. That is good for claustrophobic patient and also obese patient. It's rare in Japan, but still there is an obese patient. And another technique is a quiet. The Toshiba MRI is actually very quiet. And also the third is a visual effect. It's to make the patient more and more comfortable. Thank you for your attention.